aesthetics, as you can see, has become incredibly sophisticated. And we're talking about nuances in color, in shape, in form. We're talking about 0.5 millimeters and less at times. And we're taking aesthetics really to a whole new level so that an implant-supported restoration is in no way discernible from the adjacent tooth, adjacent natural tooth. So we're going to take you through some of the emerging concepts and tell you how we, as a group, Team Atlanta, Team New York, have come to think about it. Let me grab a pointer. Very insecure without my pointer. Den, you want to introduce? I'm Den. You're not Den. You, Steve. You want to introduce them?
Yeah, Dennis wasn't able to make it. He had a scheduling issue. But he sends definitely congratulations to Dentsply for the recent announcement. I think that's a very exciting thing, and David and I will try to obviously address that. A quick thing is that David was my dental anatomy teacher at University of Pennsylvania. He was only 30 years old. I was about, I guess, in my...
4.
Yeah, no, I wasn't 4 years old. There's not that much of an age difference between us, but it's great. I've had an opportunity to practice with Dennis and also David being one of my teachers as well, so it's great to be with you, David.
Thank you. This is then Team New York, our particular team. Maurice Sulama, who's a periodontist, many of you know as an orthodontist. Henry, who has been a mentor, teacher, friend, and Ma El Sayed, and of course our founder, Ron Goldstein, really, who formulated for us many of the ideas on aesthetics, if not on implants per se. So what we're going to try and effectively give you is how do we maximize the aesthetic outcomes when you place implants into immediate sockets? I mean, firstly, you know, this is a somewhat confusing issue. So we're going to address several factors in it. We'll talk about design of the implant. And remember, this is quite a new design to most of us. We'll talk about the net effect on bone that design may have and the changes in bone irrespective of design. And then we'll talk about soft tissue components. And as you can see already, there are a multitude of factors in the soft tissue components. When you look at immediate implants, I mean, we have a tendency to look at survival. Survival really means remarkably little. What exactly are we talking about when we look at survival? You look through all of these studies, survival means that they stay there. They stay there, they retain a restoration. What we're looking at more as a group now is we're kind of looking at changes in the soft tissue as the net result of the survival. And when you look through all this, it's really quite interesting because only one study really stands out. And that, of course, is Mike Block. Most people really lose bone, and Mike's kind of shows that he gained bone. That may well be, Steve, because...
Yeah. And the survival, the one thing that's amazing is that once the tooth is extracted, the socket really wants to do one thing. It wants to heal. So the survival numbers are very high. The real question, as David alluded to, is really about, you know, the aesthetic components associated with it. There's been a discussion, David and I had discussions about osseointegration. Dennis has worked a lot on this, and I was able to work with him on some of the case studies that we had done. Discussion about do you get osseointegration if you don't place a graft in the gap is a very interesting one. And I don't know if they can just play the video, but the bottom line is the following, is that osseointegration and aesthetics are two separate entities. It's very important to understand that what happens is that as long as you don't lay a flap and pull the tissue over or the epithelium close to the surface, the epithelium can't migrate until the underlying tissue matures or fills in. So that's one of the key elements. And again, this is a paper that will be published this year in PRD and Martin Evans Journal. And it basically shows that at 1 week you can see here that as long as the flap is in advance forward, that the clot underneath can organize. Seen over here, this is after now just a couple more weeks, 6 weeks. You can see how the tissue is maturing underneath. This is without a graft. Again, you can see the different time frames, 6 months, 8 months, the restoration, then after removal. It's interesting to note that the patient originally had a gap of about 4¼ millimeters, and on the CT scan you can clearly see that there's been collapse, about 1 millimeter, because the CT shows that it's about 3.1, so you lose about 1 millimeter. And therefore, you can get integration. And that's osseointegration, which is a totally different question than obviously aesthetics, which we're talking about the buccolingual changes that can potentially occur. And you can get bone contact to the first thread. So that is a very, very important discussion to delineate, can I get survival and integration versus aesthetics? And all these issues about Stropp's article, I don't want to go into Stropp's article, but, you know, he didn't delineate what type of tooth he took out. He took out teeth that had periodontal disease, fractures, endodontic lesions. Of course, he had shown he had 6 millimeters of buccolingual collapse. Do we necessarily see that, which we'll talk about some of that data? The answer is no. Are you getting collapse? Yes. In this particular patient, it's 1 millimeter. If it was a first or second molar and you got a millimeter buccolingual collapse, doesn't matter. Obviously, for an anterior tooth, it could be potentially a problem. So really, it's about aesthetics, as David had alluded to.
Aesthetics is a big issue, by the way, and part of the reason for the study is really our early arguments. Dennis was, you know, implicit in his belief that we got bone up to the first thread, and we had got bone to implant contact.
And you do.
That is one issue. You do. But we still suffered aesthetically. Aesthetically, we're talking about the illusion of a root eminence, lack of shadowing, the depression that subsequently comes. So these are subtleties in implants, not the subtleties in the healing process necessarily.
Yeah, and as David said, Mike Block, who's here, you know, Mike, if you really read, I love Mike's paper. First of all, I had contacted Mike about doing some research. I don't know, Mike, I think I'm seeing you back there. Don't forget, Mike had a gain, and some people I've heard in the lectures say, well, look at Mike Block. He got a gain on immediates. Mike Block grafted. Some people didn't. Peter Worley in 1998, we were doing, you know, putting in the widest implant to fill the socket, putting it as far forward as possible. He got 1 millimeter of recession. So our knowledge base of what we know now is just tremendous. And as David said,
I mean, we've been talking about, you know, the tissues, the issue. Many people have played on this in various forms, and other people have said, really, it's the bone that scaffolds it also, sets the tone. And as we've wandered around implants, I mean, this may well be the fact. It's really the buccal plate that determines your fate.
And Stephen Brown just whispered that in my ear the other day when I was sitting next to him. So Stephen said, you know, great.
And that, you will see, is a real factor in all that we do.
Now, this is a very interesting situation. I had treated this patient a while ago before really understanding a lot of the variations. And a lot of the studies look at vertical changes. So here's just an example of a patient that had a fractured tooth. I treated this patient with Frank Salenza Jr. when I was practicing by myself for many years. And here's a perfect example. Here's the final restoration on tooth number 9. And you can see here that I've managed the vertical component of the soft tissue extremely well. And we can do that with 2 factors, our abutment or crown contour. Barry, I think, did a beautiful job. I'm going to call Barry Brilliant Barry, because you did such a gorgeous job today. And you can see here the implant. But the fact of the matter is that you see discoloration, not just at the soft tissue level, but it's really throughout the whole length of the implant. And again, this is just naivety, not knowing. And you can see here, the buccolingual collapse is something that you cannot manage with your contours. And that's the biggest factor of all. That buccolingual collapse cannot be managed by your prosthetic expertise. And as David alluded to, what about the shadowing? We don't even know what the visual perception thresholds are. If you lose 2 millimeters, if you lose 1/2, if you lose 0.3, if you gain plus 0.3, boy, we have a lot of work to do, that's for sure. So and you can see here, remediation can sometimes be extremely difficult. This is a patient that walked into our practice, and you can see here that even with remediation, no bone in the buccal, bone graft, dermis. I know that Dennis Tarnow is working a lot with Dennis Thompson on The perioderm studies, he has a couple on the project and some very promising information that come down the pipeline. Hopefully Dennis Turner will be able to present that in the future. But even with remediation and doing all the things that we know so well, that some of the results can be limited. And you can see here an improvement, yes, ideal, no. So obviously we'd like to avoid that. So when we're really talking about aesthetics, David and I want to cover certain critical key factors.
When you look at them, these are the factors. When we talk about contour change, we're talking about bodily movement into the screen. It's an actual movement creating a depression, or the lack of what used to be an eminence suddenly become a flatness, a depression. It's a bodily function. A separate issue is soft tissue thickness. How thick is the tissue in the area from where the abutment head is to where the restoration emerges out of it? So we're going to measure it at different levels. And that's a completely separate thing. And we can manipulate this with restoration and abutments, but this we can't really.
They're separate, but they're also interrelated.
They're two really definitively separate issues that do become interrelated biologically. The next thing, of course, is tissue discoloration, which is a completely separate entity, but again, is the net effect of this and this, both. So all three things are very much related.
And the questions that we have is really in relation to what are the problems. We'll try to identify in each of the groupings some of the problems that are associated with it, some of which have already been elucidated. And again, what happens when we're talking about immediate single teeth in the anterior region? What about putting on an abutment or a provisional right away? And of course, some of the other goodies that can be sprinkled in, like a bone graft, connective tissue graft. Marie showed a gorgeous perioderm connective tissue graft, and that raises other questions as far as, which is better. But clearly, we can do some of those comparatives to see what that's about. And then the last 20 minutes, what we would like to really do is identify current knowledge with the Dentsply system and plus the recent acquisition as it relates to specifically the potential for multiple anterior implants, specifically the TX profile implant system. Jörg Nana from Germany, we have some interesting concepts that we would like to do, and also working with Team Atlanta, so we can try to delineate some of the future potentials and addressing the recent acquisition with the Astra company. So the first really issue is, if we look at buccolingual contour change, David, really, what are the problems associated with that?
The problems are buccolingual contour change is inevitable. Unless you do something, it is going to happen. That's the first thing we know. And when you look at the data, not our specific data, this is Tomasi's, issues to remember that affected the position of the implant opposite the alveolar crest, opposite the buccal wall, and its buccolingual relative position influences the amount of buccal crest resorption, meaning the closer you get to the buccal plate, the more you're likely to damage it, essentially. The distance change, this is really important. Reduction of buccal vertical gap is dependent on age of subject, which is obviously a factor. The size of the residual gap was dependent on the size of the initial gap. So meaning you left a big gap right at the outset, you're going to be left with a big gap. And the thickness of the buccal plate is a key issue, because if you've got thin buccal plate, you've essentially got two cortical plates in apposition, very little medullary bone to start the process of healing. And the last issue is the distance change between the implant surface, the outer implant surface, and the outer bony crest are significantly affected by this thickness of this buccal plate. So we're talking about how thick is that buccal plate right at the outset. Go back one, sorry. All right. this is really from the same group again, Ferris. Essentially, the thickness of the buccal wall, as well as the dimension of the horizontal gap. How thick is the wall at the outset? How thick is the gap? Influences the amount of alteration you see following immediate implant placement. That's the real key. A lot of other factors, most important, the last line, the use of grafting materials seems to significantly improve all treatment outcomes. Grafting does do something. So 2 things to remember. Bone resorption is going to take place. Grafting seems to change it.
So let's look at the study that we were talking about. We're just going to go through some of the issues about that. And the most critical key words, the 2 words that you really need to remember, is tissue preservation. That's important. And it's really about the pink aesthetics would be the tissue and the red aesthetics.
Steve, when we looked at this originally, it was quite a fascinating process. I mean, even within our own individual communities, this was very, very much like, the wild, wild west. I mean, everybody had opinions, very definitive opinions. You might want to liken this a little to religion. These are my beliefs, and I'm staying with them. And then 2 weeks later, if you didn't like them, I have others.
That's true.
And this is exactly what we did, depending on the meeting. Yeah. So a lot of these things are things that have evolved as we've gone through the process. So essentially, we're giving you our lesson du jour, our version on how that extraction socket should be managed today. This is, as I said, a multi-center study. Atlanta, the group in South America, the group in New York. And we really compiled our data, and Stephen done a remarkable job, particularly again with Maurice in bringing it together.
Amazing.
I mean,
thank you, Maurice.
You have no idea the amount of physical activity that goes into measuring 3 points above. And we've got different systems of using it now, but from the outset, it was incredibly difficult. And we're going to talk really about dual zone socket management, a term that Dennis really came up with, because we considered that there are 2 definitive zones, the tissue zone and the bone zone. Very, very different, and very different things that take place in it. So, dual zone, as Stephen alluded to, remember, the pink means unsupported tissue. It's the free tissue. It's the tissue above the head of the implant. And the red is really the tissue below the head of the fixture. So looking at this over here, this is your pink zone, this area over here. And then when you go to the red zone, it's the zone beyond that, apical to the head of the fixture, where you already start to have the activity of bone influencing that tissue. So it's not tissue on its own, it's tissue and bone. So Steve, let's go through some of this data.
What was great is that it was a retrospective analysis. Team Atlanta actually had up to 4 years of data looking back. And it's a comparative study comparing the contralateral tooth. We looked at provisional restoration and bone grafting. So again, we were specifically looking at bone grafting. We know there's other data out there about soft tissue grafting as well. The majority of the patients, really about 70% of them, were central incisors. The data set will be probably close to over 60 anterior teeth in the study. The key factor is that these are non-platform switched implants. And we'll talk about platform switching because that's the other part of the current knowledge that we have today. So again, large majority were central incisors. You can see here no flaps were raised in the study. They were all type 1 sockets, so the buccal plate was intact. We used either the contoured abutments or full provisional restoration. Some of the cases that Maurice had, actually, he put a stock abutment, but that would fill up the area, which we'll talk about. And then, of course, what type of bone graft material to be put in. We're actually looking at that with much more detail. in reference to that. And again, we remove the subepithelial connective tissue grafting group. Maurice is working very hard on that. That's basically what we were looking at. So again, anterior teeth, where it's retrospective study comparing the contralateral tooth. Now, a lot of the data, if you really read it in the literature, really only looks at maybe 1, 2, or 3 points of reference. What we actually did is, you could see here, we measured the cast, we put tape on it, but I think one of the benefits of the study is that we looked at buccolingual change at 7 points of reference. We basically looked from the free gingival margin down to 9 millimeters. You may say, well, what's the big deal about 9 millimeters? Well, some patients come into our practice and they lift up their lip, and they complain that they see discoloration. So that's the reality. From 0 to 3 millimeters, as David eloquently had said, that's the unsupported tissue. And dentists would classify that as the tissue zone. And from 3 millimeters apical, again, that would be the bone zone. So again, we're looking at contour change. That was one of the parameters that we looked at. We, of course, know that with present technology like Sirona System and Geomagic is a company that's in North Carolina that we can do 3D imaging and we can quantify it. So it's not only just looking at it with calipers, which has been the standard, but we're obviously moving toward quantification using digital factors. There are basic 4 treatment groups. The first treatment group is basically where we just extract the tooth and do nothing.
There's really nothing done. Tooth comes out, there's no graft, there's no provisional restoration. You let the tooth come out, you put the implant in, there's a gap, and on goes the abutment. So that's pretty basic. The second treatment group, we put the implant in, no graft, but we do put a provisional restoration. You're going to wonder, this provisional restoration, what exactly is it doing? That's a key question. What exactly is the provisional restoration doing? The third group, we put in the implant. We add a huge variable here, and that's the graft. So now you've got the graft and the provisional restoration. Do these work synergistically? What exactly are they doing? And then the last one is graft. No graft and provisional restoration. And then you don't have the provisional restoration, you have some sort of abutment.
Right. Healing abutment,
but just... a flared abutment, it could be a balanced abutment, it could be a non-profiled abutment.
And that's very common. I mean, again, Maurice had a lot of those patients where, for whatever reason, he couldn't maybe put the implant in function, but he was able to put a bone graft in the gap and just put a stock abutment on or a contoured abutment. And that's the clinical reality. How many people are periodontists here that have a referral-based practice? And that's your reality, because you go, I'm working with a GP who knows nothing. I know Steve Campbell and Tom McGarry here were prosthodontists who are cross-trained. I mean, that's a different story, that they could do things themselves. But in a real-world scenario, maybe type 4, the group 4, was the clinical reality, and that's what we really wanted to look at. I'm going to try to simplify the numbers as simply as I can. And the numbers are not really that hard. This is really basically the results. If you look at the 4 groups, again, 0 being the contralateral tooth. Notice everything is in the negative column. Why negative? As David said, it's collapsing. What we wanted to do is preserve tissue. We want to minimize the amount of collapse. I think that's the key factor. And you can see here that obviously the groups that did the best were the ones that had the bone graft and the provisional. Now, again, these are tenths of a millimeter of changes. This is not millimeters, and that's something you have to understand. But a millimeter of loss in the tissue zone could be detrimental for a patient with a thin tissue type and a high midfacial smile line. So that's a key factor. So again, you could see what all these numbers are, and the difference between the groups that did the best, putting the bone graft in, and the provisional versus doing nothing, was about 0.5 millimeter greater tissue preservation. Now, 0.5 millimeter may not seem like a lot, but in the periodontal literature, that is huge. That is huge. In the bone zone, if we look at the data again, 0 being the contralateral tooth, these are basically the numbers. Again, if you do nothing, it collapses. Grinder's recent paper also had a number, doing nothing. What's the number? 1 millimeter. What's our number?
1
A
millimeter.
millimeter. Again, putting the bone graft as you expect in that gap helps to preserve and prevent collapse. The difference is in the bone zone between those groups is now a millimeter. So the tissue zone, how much tissue? Maybe that I could preserve? 0.5 millimeter. In the bone zone, about 1 millimeter. Again, these are not difficult numbers. 0.5 to 1 millimeter. You'll see those numbers coming up all the time. Now, this was the most disturbing to me because as a prosthodontist, putting provisional on provides a great service for the patient. They walk out with the tooth. Well, what a great service. Patient comes in, the tooth comes out, they walk out with a tooth. And we know survival is very good. But if you look at this group between number 1 and number 2, there's very little difference statistically. And clinically, may not even be relevant, which means the following. The provisional does absolutely nothing. Is that true? I mean, that really bothered me. If you talk to a lot of people, I always put it on the provisional. How do your cases look? Great. They look great. So, it really relates back to attachment. And the key factor here, if David can go over some of these articles about attachment.
The key issue over here with Abramson's early work was attachment, reattachment, taking it off. And the fact all boils down to the fact this area colonizes with bacteria. As this area colonizes with bacteria, it periodically leaks. When does it leak? Only when it's pumped. If it isn't pumped, it may not actively leak very aggressively. It may be a very slow leak. As it leaks out, it comes into contact with the bone. Bacteria cannot, anywhere in the body, come into contact with the bone. We ward it off. If you have a periapical lesion, we ward it off. And we have connective tissue around it. So connective tissue forms as the bone resorbs. You get an inflamed zone of connective tissue, and then you get a healthy zone of connective tissue. Then you get the bacteria. This is what separates the bacteria from the bone underlying it. So the key issue is getting bacteria from this central core, and we know they do, particularly in this type of implant, and coming out laterally to the side where they come into contact. Remember, we were placing these, or Brannemark defined them, as placing them equilevel with the bone.
And we know that if you remove just a healing abutment, how many of you have removed healing abutments for the first time and it bleeds? Right? So, you can see that you can have bleeding. Now, let's take that now to the provisional group, which by statistics did very poorly.
But
and let me just
explain to them, when you see bleeding, is that a good sign or a bad sign?
Well, it's one of those things. At a late night in Florida at one of the Seattle study clubs, there's David and Maurice having scotches, and at 12 midnight, we're having a discussion about, well, Maurice, when you remove those abutments and the crowns, did they bleed or not? He had to go back to the data because we wanted to actually explore this as an issue, because I know in my heart a lot of these cases did extremely well. Here's just one example of a patient who has a hopeless tooth number 8. We put the implant in. There's no bone graft, just the provisional, the x-ray at the time of placement. And you can clearly see here the difference in time frames. Now, look at the 2-week mark. It almost looks like something is constricting physically around that provisional and how it heals up to the 5-month mark. And at 5 months, I'm ready to remove the provisional for the first time. And when I do, it bleeds. Actually, Dennis Tarnow came to the office. Oh, hi, this is Francesca. He's tapping on my shoulder. He goes, oh, you ready to make the impression? Oh, how's the tissue look? Great. He goes, he noticed, there's bleeding. So the real, I guess, I don't know if it's esoteric or not, is what's happening. Because is there collapse? This is the final restoration. Is there collapse? Yes. I'm not going to deny to you that there's not collapse. But is it close to 1 millimeter? I'm not so sure. And what I love about Dennis's technique of not having to do anything more than just maybe placing the provisional or bone graft, look at the periodontal morphology. It's perfect. no scarring, minimally invasive. I love that. It's easy. And again, back to adherence or attachment, Jens Verhaag, who was Jan Lindy's teacher, was doing this back in 1956.
Right, and the issue is, as you should most periodontists know, is that we do get adherence. We do get attachment to acrylic, certainly virgin acrylic, non-infected acrylic. And that attachment seems to take the form of junctional epithelium. And it looks, diagrammatically something like this. So when you have that attachment, that adherence, and you take out your abutment, you get bleeding. What's that attachment doing? It's really putting the lid on the socket. It closes it up for you very effectively and harbors off ingress or egress of the bacteria. This is kind of what we believe it is doing. So bleeding may actually be a good thing, and then the question becomes, if it has bled the first time, as we talked to Dr. Piatelli, and you take it out, you leave it lying on the side, you put it back in, do you have the potential for reattachment? And or now do you have really a keratinized epithelium
and in that
growing
discussion,
down?
And in discussion, maybe, as Herman had said, that maybe the attachment after maybe the tissue matures is a non-factor. The question that David and I and Dennis and Team Atlanta want to raise is the following. Is it critical during the early healing phase? Dr. Piatelli, is it critical? Because when we remove abutments and we see that we don't have bleeding, here's just an example. We see recession. And again, I remembered, I don't know if it's the Scotch Maurice or not, but he says, what the hell are you talking about? And then we had this discussion late night, and we realized that, hey, let's look back at that, because this is just clinical observation, but observation leads to research. So again, you could clearly see here that if we didn't have bleeding, we saw recession midfacially, and clearly there's collapse. And that's a very interesting discussion. So let's go through some of the data. Just the provisional, no graft. Look at the difference in the numbers. We have collapse, but we've had adherence or bleeding. It was about only 0.5 millimeter of collapse. If we didn't have adherence, the tissue collapsed 4 times more. The tissue collapsed 4 times more. And again, in the bone zone, the bone collapsed twice as much. So again, the soft tissue collapsed 4 times as much, and the bone zone below the head of the implant collapsed twice as much. That's what the data is showing. Was the trend also true if we placed a bone graft in? So now we're saying provisional alone, now with the bone graft. What happens with the bone graft if we put it in? Was the trend also true? The answer is yes. Here's an example of a patient, hopeless tooth number 8. We extract it. Now here you can see a graft is placed in. The other patient did not have the graft placed. At 5 months, that is perfect, healthy tissue. That is pristine tissue. That's not infected tissue. And of course, when I remove it, bleeds. You can see here a little bit more, just the abutment at insertion. Patient close-up view, thin tissue type patient. Both patients I showed you, thin tissue type patients, high-risk patients. Of course, Dennis says, hello. So clearly you could see these trends. Now again, if we look at the data, bleeding versus no bleeding, now we put the bone graft and the provisional. Look at the numbers. What does the 0 mean? No change. So the tissue zone numbers, is there any change at the tissue zone? No. It's a 0. That's good. That means we have no change. And in the bone zone, also a 0. Food for thought, something to really think about. So if we have adherence, again, we're not seeing almost 1 millimeter of collapse with the provisional. Maybe it's about 0.5 millimeter. Is 0.5 millimeter anything to write home about? I can't tell you that, because that's an ongoing study that we're trying to do on what the visual perception would be. We don't know. And again, in the group that we have the bone graft and the provisional, we don't seem to be losing anything. Again, it's a 4-year retrospective study. So I think that's a pretty powerful piece. It's suggesting certain things. Now, again, like I told you, the numbers you only have to remember is 0.5 to 1 millimeter. Because, again, if you had adherence in the tissue zone, how much could you gain? 0.5 to 1 millimeter. And in the bone zone, it's about 0.5 millimeter. Of course, you know the bone is doing something in the bone zone. It's supporting the bone, so that's the key factor. But this is the great question. What is the frequency of adherence? Meaning that how often of the number of patients that we looked at, 54, how many of them actually had bleeding or adherence? Only 2/3. Not great numbers. We need to improve those numbers. We need to do research to really improve those numbers. So those numbers are not great, and we'd like to obviously have them higher. And let me just tell you the worst patient and the best, because it tells you what the worst thing could possibly happen and the best. The worst is actually my brother-in-law. Thank God he just doesn't have, a high lip line. And this, again, he was treated a while ago, but he lost about 1.5 to 2 millimeters of collapse. 1.5 to 2 millimeters collapse. But these are our best patients. If you do nothing, you never get into the positive category. Never. But our best patient, just putting the provisional alone, now is in the plus category. And of course, when you put the provisional and the bone graft, you're now in the plus category. Don't forget, we haven't done a connective tissue graft. All we've done is bone. So, of course, the best group is in a very high positive number, but the provisional is also in a positive number. And actually, just putting the bone graft, just the healing abutment, also potentially can achieve positive numbers. This is the range. The best patient in each group and the worst. Because you have to know what the range is.